talk about Window on the System and spotlighting some of the themes. Annie, over to you.
Thanks very much, Steve. Yes, so I think many of you, perhaps most of you, know who we are, in as much, and you've got our pictures there. We're a group of professionals, experts, if you like, from different parts of the safeguarding system. And our primary role is to oversee the national system of learning from serious incidents. And as part of that, as well as doing national reviews, thematic analysis and so on, we have a responsibility to every year to produce and publish an annual report, which gives us an opportunity to do a bit of stock taking on the basis of the evidence from serious incidents about the health of the child safeguarding system, to identify patterns in serious incidents, review work, so that we can together improve safeguarding practice. This is our 5th report, and we hope that you think that it provides you and all of us involved in protecting children with some useful insights about what's working and also what is not working so well. The theme around continuing to enhance the way in which we work together as agencies, as professionals, is kind of underlined once again in this annual report, as it has been in many other work that we've done and that others have done. Emphasis as well on effective information sharing and using that information to understand what's happening in a child and family's life, and through that to address some of the barriers to improving safeguarding practice. Now, during the course of the year, we commissioned that's under review for this, which is 23 to 24, so that's April 23 to the end of March 24. We commissioned 2 national reviews, the review which we published just before Christmas about child sexual abuse within the family environment, and then a review about a child called Baby Victoria, which we haven't yet published, but we intend to do so over the coming period. We've also commissioned 2 thematic analyses, one about neglect and the other about race, racism and racial bias. And I think you'll see from the some of the kind of evidence in this report, the importance, the primacy of those themes in safeguarding and how we need to kind of address some sort of really important kind of issues. And then last but not least, we published a briefing on elective home education. We published that, I think it was in April last year, and I think it's been quite germane and quite important in providing evidence to government about the need for some legislation in this space, which of course is being brought forward through the current legislation that's going through Parliament. The other thing to say about the annual report is that this year, as last year, we have also, I think it's in chapter 3, we've reflected on the context for safeguarding practice and some issues about the conditions. So issues about workforce, about the availability of appropriate placements for children, and really re-emphasize the need for some design changes in how we work together to protect children. And of course, the Children's Wellbeing and Education Bill, which is now going through Parliament, does address some of those issues in terms of the making mandatory multi-agency child protection teams, the elective home education requirements, and also work in relation to placement provision. So that's a kind of quick overview of what's in the report. If we go on to the next slide, we pull out some of the kind of key headline statistics. So the first thing to note is of the 330 serious incidents that were submitted in this time period, which actually generates over 400 reviews, because you've got some incidents which have generated a rapid review, but also an LCSPR. What's interesting, and we noted, is that there was an 18% decrease from previous years. Now, the number 330 is relatively small, but what I think this does signal to us is that we need to kind of track carefully those ups and downs in serious incident notifications and to understand, for example, is this decrease, and it was primarily in terms of numbers of serious harm notifications rather than children who died, is that because there is notification are not happening where arguably they should, or is that because there has been a diminution of those kind of serious incidents? And I don't think we know that, and it's something that ourselves with the Department for Education will be continuing to review. 50-50 are about death of children versus serious harm, and of course that serious harm criteria is always the one that's more open to interpretation. It is different from significant harm. It is about serious harm, and in the guidance that we're working on at the moment, we've really sought to try and be as clear as we can be, because at the end of the day, these are professional judgments about what kinds of scenarios indicate serious harm. A couple of other things to pull out from that slide. I mean, firstly, 36% of the incidents were about children under 1, and that of course reinforces the kind of very vulnerable nature of very early childhood, and the number goes up if you look at the sort of under 3s, for example, so children who are not less likely to be in some kind of education or childcare provision. The other age, of course, that is, if you like, dangerous and high risk is, of course, late teenage years, sort of 15, 16, 17-year-olds. And that's where you also see a high percentage of incidents. The bit in the middle is really important and will segue into the report that we will be publishing quite soon about the thematic analysis about race, racial bias and racism, because it highlights again the overrepresentation of some groups of children, Black and Black British children, and the underrepresentation, that's not there, but it's in the report, of children from Asian backgrounds. And we start to kind of tease out and reflect on that in the report, the thematic analysis report that will be published soon. Sorry, yeah, there's the Asian. You can see the disparity between the population and their presentation of Asian and Black children, respectively, in serious incidents. Two other things: the high presence of neglect in 49%, not always the kind of behind the trigger incident, but clearly a pattern of neglect in children's lives. And then this last slide from me, which is a bit more about the window on the system, the patterns in practice that we can see. So firstly, 10% of children reported to be home educated, which I think is a similar figure to previous years, but I think it does reinforce the importance of some kind of stronger legislation in this space around this group of children who, the vulnerable children who are being home educated, are especially vulnerable because they don't have the eyes and ears of schools. And then another 15% of children who are not enrolled in school. And so that kind of whole education dimension is so powerful whenever you're looking at any of these serious instances, you will all know. 9 out of 10 instances of family had been known at some point to children's social care, not altogether surprising because we're talking about the most vulnerable children. But on the right-hand side, you will see a much lower proportion, about 27% of children who had been or were on a child protection plan. So this year's annual report, what we decided to do was to focus on 3 particular themes which have come through year on year, and we wanted to do a bit more of a deep dive, and you're going to hear about the first 2 in a minute from Jenny and then Sally. The third spotlighted theme is around extrafamilial harm, and that's going to be the focus of our annual report webinar next week. So I'm now going to hand over to Jenny to take you through some of the findings about children with mental health needs. Jenny.
Thank you, Annie. The reason that we decided to have a focus on mental health within the annual review is because of the feedback that we'd had from safeguarding partners saying increasingly this was an area that they were looking at and were concerned about. And so therefore looked at two areas, one specifically around children with mental health needs, and then the second area looking at parents and carers of younger children. So just to give an overview of some key stats and figures, 22% of the children had a diagnosed or undiagnosed mental health condition. That's 22% of children where they'd been rapid reviews or local safeguarding practice reviews. And 92% of the children who died by suicide were recorded as having a mental health condition, which again, perhaps isn't that surprising in terms of what Annie was saying around the high proportion of children that had support from various services because of their vulnerabilities and vulnerabilities in their families. 96% of children identified with at least one mental health condition were aged between 11 and 17. And we'll go on and look at a specific case example. But what I would say, can you just go back? Just I'm not quite finished yet. What I would say is that what research is telling us is that younger children may well have mental health issues or emotional and health and well-being needs, but they aren't always picked up until they're older. And then finally, among children with mental health conditions who experience serious harm, child sexual abuse or exploitation was the most prevalent cause. And also, which was also picked up in our national review, that their emotional health well-being needs weren't always picked up, and there was more a focus on responding to behaviour without actually looking underneath to assess the causes of that behaviour and what support they might need. Thanks. Joe, move on to the next slide. So to illustrate a bit of what we're saying, we had a couple of case studies in the national report, but this one is about a 17-year-old white British boy who had a long history of eating disorders and concerns about neglect. And here, what was looked at in the review was around what the GP had done to support and bring in other agencies, because as we know, families and young people often go to their GP first for support. So a range of involvement by multiple agencies in terms of supporting this young person in terms of mental health needs, school nurse and as the social worker. And it also, we felt this review particularly highlighted the challenges in supporting a 17-year-old as he approached adulthood. So that interface between children's services and adult services. And some of the key aspects that this review brought out was the challenges that the GP faced in terms of referring the boy to a range of services to get support around his nutrition and some of his eating habits, because he was not under paediatric care and he was also too young for adult services. And in mental health generally, that is a finding for children who are sort of 16 and 17 years of age. And despite the involvement of various agencies offering support, there were obstacles in communication and coordination of that support. So really looking at and thinking about the support and the work that you're doing, not just from your agency's point of view, but from a broader view to provide holistic support. And the GP's attempts to get support from the multi-agency safeguarding hub, and as you say in the earlier point, that often responding to crises as opposed to a constant level of support, and early help services were met with difficulties, highlighting the complexities of ensuring that comprehensive support of children transitioning into adulthood. So that's not just with mental health services, but that's also with a broader range of services like social care. So, cross-cutting findings in children's mental health. I'm sure these are familiar to you. However, we wouldn't want to take away from the complexity of bringing help together for children and families. So, first of all, in terms of multi-agency working, really bringing a coordinated response. As I said, a multi-agency lens as opposed to a single agency lens on what practitioners are doing. Comprehensive assessments which involve the range of people who are working with children and families, so you can have a collective view and families can receive a more comprehensive, holistic forms of support. And then clear roles and responsibilities, but that doesn't mean to say working in that siloed approach. It's having an appreciation of who is doing what. Information sharing. A range of missed opportunities were brought out in reviews, but what was more important, or as important, was the proactive sharing of this information and understanding what information meant, for example, particularly around mental health diagnoses and mental health care planning. And then the voice of the child, so engaging with children and young people and their families was absolutely essential in helping them understand what assessments were being undertaken and what they meant, what plans were being put in place, and enabling them to contribute to those, and then keeping up regular communication about how children and young people are being supported and how that might change. And then, as we know, consistent relationships and relationship-based practice. So any questions that people might have? And I think, Steve, you might be picking up some of those in the chat.
Yes, of course. Thank you. So thank you for those who have already contributed your questions. There's one or two for Annie and then you as well, Jenny. Annie, when you were talking, there was a question about the impact of changing thresholds. So it's number 8, if people can see that. Does changing thresholds have an impact on what is identified as a case for review? Quick comment on that.
I don't. I think it's very difficult to give a kind of yes or no answer, particularly around this distinction between significant harm and serious harm. And what the panel does is set out guidance and things to think about, but it is for the local authority in consultation with their safeguarding partners to determine whether or not that threshold is met. I think that we probably believe, on the basis of experience and conversations with others, that there are different thresholds across different types of abuse in different areas. So, for example, in relation to extrafamilial harm, some areas may decide to notify a serious incident, for example, where a young person has been stabbed. Others, but hopefully has made a good recovery, and others may not. And there's a lot of kind of contextual, conditional factors that may shape that decision. I don't know, Jenny or Sally may have something else to offer on that.
Yeah. So lots of range of different thresholds across the country. Yeah. Another question, a couple of questions, number 13 particularly. Is it right to focus on mental health needs? Most of the children we really struggle to support are those who are traumatized. So they don't really identify as having a mental health condition, but are still struggling with trauma. And it's really critical that needs, but no legal framework accessible to support them. What about those who don't consider themselves with a mental health issue?
Shall I do that first, and then
Please,
Sally
Jenny,
might want to come as well from your experience. So that was the point, first of all, about the importance of the voice of the child, and having them as an important part of planning for support. But the second thing is that trauma is still, and it impacts on the emotional health and well-being, and early support in this space. And we, absolutely appreciate that services are really under pressure in this space. But emotional support doesn't always have to come from CAMHS and high-level services. Yes. And, we've got the examples of areas that got mental health teams in schools, but also in good training for family support workers and social workers as well around other people in the health space and teachers about supporting that the emotional support, giving emotional support to children and people at an early stage. Sally, would you want to? And we had some examples of that within reviews and a feeling around certainly in terms of improvements that local areas were hoping to implement. Sally.
Yes, I would agree with you, Jenny. And in the report, we talk about diagnosed and undiagnosed mental health needs. And I think you're absolutely right. There are children with diagnosable mental health conditions, but equally there are a lot of children who are affected by trauma, and actually the impact on their emotional well-being is very similar. It's similarly devastating for them and their families. I suppose what the difference is, it's around the CAMHS threshold, isn't it? And those who have got a diagnosable, treatable condition have access to those services. But we also need to think about what services are available, because in my experience, some of those traumatised children can present greater challenges to services than those with a mental health condition. So I think we didn't want to exclude any particular group from that, just recognising that the impact is equally devastating for both types of children who are experiencing emotional distress.
Yeah. Thank you, Sally. So a couple of comments next. One is that the case study is identical to what I'm dealing with at school. The children's services have immediately closed the case and are not in a position to offer any early help or support. I think that's probably replicated in a number of different areas in the country. And number 19, preparing children for adulthood near the post-18 cliff edge in a mental health space is a systematic and endemic issue beyond the power of local SCPSs and needs wholesale government reform and legislation change, dedicated leadership and increased funding across the NHS. Well said, but we are living in a world that necessarily has those restrictions. Quick comment on that is that pick up on the case study and again the thresholds issue, or perhaps looking at the transition, preparing children for adulthood. Okay, let's another. Go on. Sorry, Sally.
Steve, the only thing I was going to say, so that point about early intervention and early help, which in relation to this group, but I guess it's a kind of wider concern, and I think we do comment on that in our report in the chapter on conditions and context. The sort of hope and expectation is that the development of the kind of new Family First Pathfinder and the sort of the legislation that will go alongside that will over time enhance the kind of quality and robustness of that early help offer across the country. And obviously there is some new money coming in to enable local areas to kind of move to a different approach, and particularly emphasising that contribution of the multi-agency kind of professional network. But I mean, that's obviously at the moment is an ambition, and we have 10 Pathfinders who are trialling that kind of approach. But I mean, there's a long way to go, and I think what that the colleague has said reflects the concerns of very many.
Yeah, thank you. There were also a couple of comments about whether or not you included the traveller communities in the study, and I see probably members of the panel have been answering these questions as well, saying read traveller communities. Page 29 of the annual report sets out ethnicity breakdown of children. 0.6% of children in rapid reviews were from a gypsy or traveller background. So effectively 2 reviews.
Yes, I put that in. It is a relatively small number, as evidenced by that. That's not to say that that's not important. And I think in those reviews, there is recognition of the need to really understand those communities. And we know that, some research has been done about looking at child protection in relation to gypsy and traveller communities and some of the particular kind of considerations and challenges of that work.
Thank you. Please, if you want to pick up a question that I'm perhaps missing, or you feel you want to just verbalise it, just use the MS Teams raise hand and we'll come to you. And we'll shortly hand over to Sally Shearer, but we'll come back for more questions afterwards. But just before we do, the number 33, is there any focus or research in looking at the source of the initial trauma, harm, abuse or neglect? And are parents in high risk areas offered support and guidance on the needs of a child? Kind of a rhetorical question, but perhaps some of our colleagues have examples of how they are managing that sort of early help or identification of that level of risk. Maybe a comment, Jenny, is that your area?
I thought you were going to come to me, Steve.
Yeah.
I think actually Sally is going to be picking up some of that in terms of support for parents, aren't you, in the next part of the presentation? But if it's not picked up, then we'll come to it in the end of the questions. Is that
what a brilliant
that's
segue?
Okay, folks, rather than repeat ourselves.
Thank you for the segue, Jenny. And yes, so introducing Sally Shearer, over to you. You're going to pick up on safeguarding preschool children with parents with mental health issues. So over to you, Sally. Thanks.
Thanks, Steve. And we were particularly interested in this year's report because we have some evidence that parental mental health is often overlooked as a potential risk factor for children. And excuse me, when you think about the preschool age group, they obviously sit outside that oversight and scrutiny by school that Annie mentioned in one of her earlier slides. And also, although babies are incredibly vulnerable, they often have increased oversight in their first few months from their developmental and their vaccination reviews. We also noticed that this group of children aren't reflected very well within the literature. When we did a literature review, there isn't a lot written about preschool children, and based on our own data, we could see particularly where they have parents that have got mental health needs that can have a significant impact on small children at a time when they're really wanting that stability and a nurturing home environment, which was why we picked this as one of our themes this year. We found that over half of the incidents involving preschool children did involve a parent that had got a mental health condition. So we had 46 children notified to the panel aged between 1 and 5, and 27 of those children had at least one parent with a mental health condition. And when you compare that to the full cohort of 330 notifications, it was 25% across all ages where the child had at least one parent or a relevant adult with either a physical or a mental health condition or a learning or developmental disability. I mentioned that there were 27 children aged 1 to 5 who had a parent with a mental health need, and of those 27 children, 15 of them died and 12 experienced serious harm. And as we mentioned earlier, that serious harm is it's beyond significant harm. And then we also found that for both alcohol misuse and substance misuse, 41% of those reviews involving this cohort of children had a parent with either an addiction to alcohol or an addiction to substances, or in some cases both. So just to pick this up through a case study then, this is about a little girl. She was found in her home. Her mother had died, and so the little girl was alone in the home with her mother. Her mother had been known to services for many years. She'd got significant mental health needs, alcohol misuse issues, and a history of domestic abuse. And this is a picture that we often see within panel. Very often often these families have had older children, and so services do know about the mental health needs within the home, but probably what they overlook is what impact that is having on these small children within the home. So the key aspects that we found in this case, again, which reflects many other cases that we see, is there are multiple agencies involved. Some of them are supporting the adults within the family around their mental health needs, their domestic abuse. Very often this is aligned to poverty, deprivation, financial issues. So there are agencies addressing those components of the family challenges, and then there are the children's agencies who are obviously involved in initiating the investigations and child in need and child protection plans. And we find that often agencies focus on whatever the immediate presenting need is. So if there's an issue, for example, with the home conditions, there will be interventions put in to support families to resolve those. But what happened in this case, there wasn't that stand back and have a look at the whole picture, what that cumulative and historical history of the mother's mental health and her substance misuse, what impact that was having on her children. And whilst we have seen some really good multi-agency engagement and information sharing during formal meetings, and we particularly saw this in this age group between GPs and health visitors, and some really good pre-birth planning. But what we then see is that the communication between the services that are supporting the adults in the family and the services that are supporting the children with the family aren't really talking to each other. And sometimes the risk that exists for that child is minimised, or there can be an over-optimism on the mother's ability to cope, or other family members' ability to be able to support this family. And what that results in is that lack of a really comprehensive assessment of the mother's ability to care for her child or children safely. And because the mother can sometimes be reluctant, in this case she was reluctant to access her GP, to access the care and treatment that was being offered to her, there can be a very much an on-off relating to the concerns. Things get better for a while, but again, that importance of really standing back. And if we look at this slide around some of the cross-cutting themes, that real need for agencies to work together to give that really comprehensive, holistic approach, and then think about how all of the challenges that are affecting that family are interconnected, because everything is reliant on other issues within the family, and the importance of taking the whole picture in the round can't be overestimated. So then in terms of information sharing, this comes up a lot within our reviews, but is really pertinent when you're looking at that seam between adult and children's services. We often think about how we share information between agencies, but also we need to think about how information is shared between adults and children's agencies, and really keeping the child at the centre of your work, thinking about what impact that is having, what it is like to be that child living in that home. And we see some fabulous reviews where people actually articulate the voices of children on what it was like to live there. And so I suppose that's something that we should never forget. And thinking about those challenges in engagement, these with all mental health conditions, they are quite dynamic. They are ever shifting. Things can be fine one day and can go quite disastrously wrong the next day. So always being aware of those challenges in engagement and picking up early indicators when things are deteriorating. And then, as Jenny picked up, it is only by understanding the full amount of risk and what the full plethora of challenges are that a family are facing by adult and children's services working together, that you can then put in a truly comprehensive, supportive approach in terms of early help or other support. So that's the learning that we have had with this group. We look forward to the discussion.
Thank you, Sally. Yeah, starting with a comment I think reflects how many people feel. It says Dr. Graham Allen published an early intervention report back in 2011. It's number 35. We have been here before. Annual reports have the same themes every year. Nothing changes. If it does, only briefly. After over 30 years in health visiting, I feel only despair. And I think that's a widespread feeling, and a particularly difficult area to work in. A couple of comments as well. Number 42, often adult mental health services will identify the child as a protective factor for a parent without considering the impact on the child. So one way, not the other. And colleague has also put in transition between adult and children's services is a theme in partnership reviews, and adult and children's services working together in a more seamless way. Think family, of course, is a key area for practice improvement in recommendations from LSCPRs. Another comment is with development checks of preschool children and babies not being mandatory with no chasing up, this allows children to fall under the radar. So relevant to your case study. So yeah, some good curious feedback there. I'm curious about whether the parent was reluctant or just not able to access services in a conventional way due to their poor mental health. How can the system be more flexible in how we offer support around poor mental health? So, making those services for children and babies mandatory will help that, and have health visitors visiting on a more regular basis and, following up. But is there any other way that we can help parents who are struggling with their mental health in accessing services?
Thanks, Steve. That's a really comprehensive roundup of the comments, and there's some great comments there. I think in terms of how parents can access services, one of the things that we have really picked up through our work is around the importance of engagement, and what we often see where families disengage with services or don't pick up on opportunities, they then often get closed down to services. And so what we would suggest is that agencies think about what they need to do. Don't just close down a service, to think creatively. Why aren't this family engaging? What are the barriers? What do we need to try a different way? How can we be flexible in meeting their needs? And also the importance of having that trusted practitioner from one agency who really builds up trust with families, and then starts to be able to find that way in to take that engagement forward. But I appreciate it is a really challenging environment out there.
Yeah. And there's also a couple of comments. Number 52, stigma plays an enormous part in engaging parents. We also had a comment earlier about, of course, the need for professional curiosity. I've lost that for a minute. But yes, number 43, a consistent theme in both my clinical practice and local SG reviews is the lack of professional curiosity when undertaking assessments from all partners. And I guess that also brings into, delighted to have colleagues from education represented today. Number 51 says, in school, we often have no idea that a parent is receiving adult mental health support, which means we may be seeing behaviour or be unaware that the child, what the child is experiencing at home. There doesn't seem to be there doesn't seem to be any able information sharing with children's services. Who would be the key services to inform school and work with them to support the child? There's always this gap between the statutory services and education and their inclusion in this process, and primarily, of course, because they're massively distributed nature of education in many different schools in a local authority. Sorry, Sally, that was a bit of a download, but
yeah.
some comments.
Yeah, again, great points. And we do see in the learning from a lot of LCSPRs, it is around that interface between school and other services. And I would also say nurseries include early years services in that, which is, as you say, school may be seeing some behaviours that they don't particularly pick up on because they don't know the backdrop that other services know about. So really important when the statutory agencies are working with those families that they are then able to share that information with the people who need to know. I think that there is work underway, as many people will know, within the Child and Wellbeing Bill around the statutory duty on information sharing, and also this single unique identifier. It's several years off, but I think having that common number that ultimately all agencies will use, and that will really help around information sharing. There are all sorts of reasons why information doesn't get shared effectively, and it's doing what we can to break down those barriers.
Could I just come in there, Steve,
Jenny,
as well, to say that and the comment around children being seen sometimes as protective factors when adults are receiving mental health treatment, that from many reviews, that really trying to embed a think family approach, holistic assessment. If services thought in that way, for example, an adult mental health practitioner, then they could support whoever they were working with to understand that actually the school having some information about the support that's going into the family would help them as a whole. So there's a shift in culture around thinking holistic family alongside individual support, and that's what many reviews were coming across. The other comment in there, and I think we do have to mention this, is around deprivation of liberty orders, and that there has been an increase for young people. And the comment there was about going between going into hospital for a young person, but also being in unregistered accommodation, particularly when they're older. That is a bit of a pattern that we've begun to see through reviews, hence why we've picked that up here. We've had the recent Care Quality Commission report on dolls, but it is an area that we as a panel are monitoring and have been in liaison with other government departments, and I know in your local areas and local safeguarding partnerships are monitoring that as well. So it's an area that we do need all of us to work together on in terms of support for young people. Thanks, Steve.
Thank you, Jenny. Yeah, I'll pick up on the sharing information comments there as well. But again, just to pause to see if anybody wants to put their hand up and ask a question about the content or direct to the panel.
I think just while you're waiting for hands, Steve, I think the comment around stigma is also really interesting, and also thinking around how different cultures feel about having mental health needs. And so there is a cultural issue there playing in around stigma, different backgrounds, different historical family contexts can really influence how able parents feel to access mental health care.
Yeah. And so that, stigma is the flip side to professional curiosity, isn't it? Having, that open mind and not kind of, jumping to assumptions or misinterpretations of a situation that you're facing. Just again, a couple of comments. 61, part of information sharing difficulties are around the information being about a parent, and as a result of confidentiality is upheld without consideration of risk to the child. Now, that kind of needs challenging, doesn't it? Because the welfare of the child takes precedent in that case, or in most cases. A lot of schools use CPOMs to record safeguarding. Could this not be shared with external agencies where needed? Interesting approach there. I don't know whether you have a comment on that, either of you.
I think I think that where they are at the moment in multi-agency information sharing is that there needs to be some caution, because not everybody needs to be able to see everything. So that is being worked up at the moment, but probably early days on that one at the moment.
And that's covered in the Child and Wellbeing Bill, isn't it? I think, yeah. So yeah, many parents this is number 64, many parents who are under SSD fear that they will be viewed negatively for needing support from mental health services, especially if they are experiencing a decline in their mental health. So, that's again, part of the stigma is, the individual's reaction to seeking help and not wishing to be exposed, certainly in perhaps the education system where their children are at school. I think the difficulty in sharing information is that systems do not communicate easily with each other. Different agencies use different platforms. This is the case, but technology is getting so much better now and able to link between data sources. It's often the assumption that data can't be shared that gets in the way of the relevant data being shared with the relevant agencies. And we know that comes up a lot. Different health systems, different systems within health, of course, and people input the information into systems. They are only accountable for sharing. They are also accountable for sharing the information too. So having the right data in the systems is one thing. Understanding, as Sally said, the protocols and the ways that data is shared with different agencies is another thing, and that's more of a mandate in the discussion. Any questions? We're sort of coming to the end of that. I do invite the panel to review all your comments in detail. They've already begun answering the questions. Thank you very much for that. And we will do that analysis and we will produce this as a report. It will go alongside the video recording, which will be edited a little so that there is permanent records. So if you have colleagues who haven't made it to today's webinar, please point them towards the DFE National Review Panel website, and that will be up in a few days' time, within a week, let's say. Good. I don't see any hands. So Annie, I'm going to pass over to you.
Okay, I was actually, before I do sort of concluding remarks, just to sort of pick up on a point that was made earlier on about it was somebody who said been around for some years, and that there is that sense of the themes are perennial, they keep coming back, and I think in one sense that's true, and I think it's likely always to be true, in as much that we're talking about a work practice. Do is to have the best possible systems and for professionals to share information. Sorry,
Annie, you're breaking up slightly, so I think just repeat that last point, please.
Okay. Sorry, something seems to happen. So I think what I'm trying to say is that these are perennial themes, and there are things that we can do, and I think some of the legislation around multi-agency child protection teams is an important new departure and gives us some real opportunities to address some of those perennial themes. And also the work that we do is about understanding and addressing and mitigating as far as possible risk of harm to children, but it's not going to be one where we can eradicate the risk of harm. And we have to kind of, bring our very best to the work of protecting children. And that is about curiosity, about good information sharing, robust decision making, and so on. But I think some of these issues will continue. We just have to do our very best to address those issues. Is that right? I'm not.
Yeah, that's fine. You are breaking up a little, Annie. I think if it continues, you might turn your camera off, which would be unfortunate, but at least we'll be able to hear you.
Okay. Well, I'll just move on. If you put your hand up if I'm breaking up, Stephen, then I'll know. So I think it's beholden to me to kind of just draw this to a close, and to thank everybody for their very thoughtful and reflective questions and comments, which we will take forward in the way that Steve described. I think lots of really important issues about stigma, particularly about mental health for children and adults, about how we do share information across agency divides and particularly across adult and children's services, and how we can really engage both children and adults in a way that is flexible and meets children's needs. And so I think it's a lot of really important themes there. Hope that this session today has been helpful, and we look forward to seeing you at other webinars in the future.
Thank you very much, Annie. And Amina has posted a evaluation survey. I know you get this all the time, but we really are keen to help improve and continually improve the quality of the webinars and the interaction with the panel. It's really important that we give you a voice in that. So please give us your feedback. Otherwise, the forum will be open for the next few days. The panel and I will be working on it to answer all your questions. So if you save the link, you can go back in at any point and add a further question or comment to the panel, and that will be picked up in the report, and we will publish the report in a week or 10 days time. Thank you very much, everybody, for spending this hour with us, and we look forward to seeing you on the next webinar, which is on the 19th, which will be roughly a repeat of this around the annual review. Further webinars coming up. Please check out on the website for dates and so on. And the mailing, to get on the mailing list, there's the link there on the slide that is showing. And yeah, please keep in touch and let us know what you think. Thank you, everyone. Have a good day. Bye.
Thank you. Bye.